Welcome to the next episode of Endoscopy Essentials. I'm very happy to have Stefan Seewald from Zurich back, Mr. Imaging. So Stefan, last time we explained the features of the new Olympus scopes.
Yes.
This time we are focusing on special challenges where we need imaging, right?
Exactly.
And the first thing is early gastric cancer we are usually not looking for because it's so rare and that's a forgotten disease. But it's very difficult to find. So please convince us of imaging.
So I would like to convince you with a special situation. I think every endoscopist in his endoscopy life will have the challenge or the situation that you get a patient referred with a biopsy proven gastric cancer and no visible lesion. So somehow we have the term of an endoscopically invisible early gastric cancer, and I think today we would like to discuss a little bit how to approach in this specific situation. So when we analyze endoscopically invisible early gastric cancer, I think we have different clinical situations or settings. So one option is that you have no visible lesion, but an incidentally biopsy-proven well-differentiated cancer.
The so-called biopsy cancer.
Biopsy cancer, yes.
Mm-hmm.
The next biopsy cancer is also a biopsy cancer, however, with poorly differentiated cancer. And this is a difference. I will explain this later. And then I think in this setting, we also have to discuss the situation of the patients with a CDH1 mutation and potential hereditary diffuse gastric cancer syndrome. So this is the third setting, and I will start with the first.
So let me just ask a question. Very, very interesting clinical scenarios. When you have that, and maybe you go in again and don't find it, at least at that stage, do you make a test whether there was a mistake in the biopsy, so it's the wrong patient?
Yeah, that's a very good question. So I think you need definitely an expert pathologist. And before you make a therapeutic decision, for sure, this biopsy have to be again
reassessed.
Exactly.
But also make sure that's really from the patient. I remember I had a case many years ago where a patient from Friday was messed up with a gastric cancer biopsy from Monday. Mm-hmm. So things can happen.
So I think in our cases, the biopsy were all from the patients.
Yes.
This is for sure also a scenario, but
we should think about. So
yes.
if you really can't find anything and know the perfectly normal stomach, think of that biopsy.
Definitely. So the biopsy has to be from the patient, and you need a reassessment of the biopsy.
Okay. Definitely. But I don't want to distract from imaging.
No problem. So first situation now, no visible lesion and well-differentiated cancer. I think the best is always to show some cases, and I would like to start the first case with an 81-year-old female. And in 2016, so 7 years ago, high-grade dysplasia were found in a random biopsy from the stomach. And then an endoscopic mucosal resection was planned. Patient came to the hospital, but no visible lesion was anymore detectable, so the decision was made to follow up this patient. And then,
which is in line with evidence. There are a few papers that biopsy cancers can be followed if really a meticulous endoscopy doesn't find anything.
Exactly.
The pathologists then say the cancer was so small that it was removed by biopsy, but that's not really satisfying, is it?
It's not satisfying. We tell this sometimes, but we have to be careful, and definitely the patient has to be followed up, and you also have to take care of the follow-up of the patient, because some patients get lost and then you may have a disaster. Okay, so this patient was followed up from 2015 to 2016 to 2023. And then an endoscopy was performed last year, and in the follow-up endoscopy with adequate remapping, high-grade dysplasia and intramucosal cancer, again without visible lesion, was found in the proximal corpus. And now we had the advantage that we had somehow a location of this biopsy.
Because that's also what you should do, not put all biopsies into one vial.
Exactly. So
do a really good mapping biopsy.
Exactly. So in this case, we knew something is wrong in the proximal corpus, and then again, endoscopy was performed in order to make a decision on the further treatment. But again, the area was not found, and then patient was referred to our center. So in this case, very interesting. So over a period of 7 years, we had detected high-grade dysplasia in this patient.
It's also interesting what the natural history is.
Exactly.
Because I remember from many years ago, there was a Barrett paper with high grade, and over 7 years, only 16% developed into cancer.
Yes.
There was a lot of criticism about that paper, but at least it's a similar thing, right?
Yeah, exactly.
Yeah.
So in this case, we have to admit that patient has an autoimmune gastritis type A, and she has a well-differentiated cancer. And we will later discuss also the growth characteristics of early gastric cancer. So when we have well-differentiated cancer, cancer starts from the mucosa. And this is very important in these patients. Somehow you have to find something in the long run and in the follow-up. This is a very important conclusion. So I will show you now the stomach of this patient. So this is the area of the proximal corpus, and somehow we are using here now our best endoscope, the Olympus XZ1 1200 zoom endoscope. So do you see here anything? Would you
Japanese
say there's
version.
Japanese version, exactly. Is there something wrong for you?
Well, you stop there. In the middle is this reddishness, which you should focus. But maybe also when you go back, there were a few abnormalities.
Yeah, it looks like abnormalities, but actually the whole stomach looks like this. And in this case, we focused on the area of the biopsy, because this is the only thing what we have, and exactly here was the biopsy. So somehow...
You see that from that little scar?
Yes, I think so, yes.
Yeah.
Yes.
Okay.
So in this area something must be. And now we have to say with the regular white light we cannot detect any circumscribed lesions. So in this case we used NBI and NBI zoom. And when we have difficult cases, sometimes we do underwater assessment by using NBI. And that we are doing right now. So we put the stomach underwater. And now we try to focus on this area of the previous biopsy. And very interesting, if you focus now here on this surface, you will notice that we are now in an area where the glands are smaller, and we also have slight abnormalities of the vessels. And when you watch here at 6 o'clock, you have regular mucosa, but here in this area, you have this abnormality. And when we discuss the fact of a visible lesion, we have to focus first on the surface pattern and then on the vascular pattern. So in this case, I would clearly say we have an abnormal surface pattern and we have abnormal vascular pattern as well.
Well, that's a tough one.
Yes.
Where does it start? Where does it end?
It is.
And there's a little bit of vulnerability.
How to say?
Tiny bleeding up there. Does that mean anything?
No, I think it is an autoimmune. It's because of the flushing, you know.
Oh, okay.
So you also have to be careful not to flush too intensively. So, but always this is a reproducible lesion, I would say, and we have reproducible delineation line. And I think I will stop now the video. I go to the images. So here we have regular surface and vascular pattern, and here we have somehow different vascular and surface pattern, and I think the demarcation line is exactly here. Another picture as well. Here you can notice nicely regular pattern, here abnormal pattern. Here as well, regular pattern, abnormal pattern. So this is the center of the biopsy. Okay, this is sometimes disturbing when you get a patient with a biopsy, But here you see the surrounding of this biopsy is also really abnormal. And yes, I think here with this technology, we could finally detect the area of the high-grade dysplasia, and the area was about 4 centimeters. And 4 centimeters, exactly. And yes, we performed an ESD.
So you have to make a very careful delineation, right?
Yes.
Point by point. And
exactly. The delineation is the most difficult thing in this ESD. And we used underwater NBI in order to delineate the lesion, and then we could proceed with the ESD. And here, this was an area of a previous biopsy where the colleagues had a bleeding. That's why this clip is there. But the clip also helped us to re-identify the lesion of the high-grade dysplasia.
Like pointing towards
pointing
the lesion.
to the lesion, exactly. So interestingly, after ESD, you see here the area of the biopsy. And now with indigo carmine, after the resection, you can nicely delineate the lesion, but this was not possible before. And when you look here at the histology, this was early cancer with high-grade dysplasia, so from the Japanese classification, intramucosal cancer. And we could fully resect the lesion or zero.
How big was it?
It was 4 centimeters.
Also on histology, like you can see here.
Exactly,
Okay.
yes. So the conclusion of this case is, if you have the histology of a well-differentiated cancer or high-grade dysplasia, and you don't find the lesion, it's not a problem to follow up the patient, but you have to know, and we have to admit, that because the cancer starts from the mucosa, one day you have to detect it, and for sure you have to use a good endoscope.
But it seems to be relatively safe to wait. In which intervals do you scope those, or would you recommend half year?
I would say I would scope every 6 months.
Every 6 months.
Yes.
Okay.
No.
But the alternative is what? Gastrectomy.
Alternative is gastrectomy, and in this patient, because there was uncertainty for the patient, gastrectomy was also recommended. But then the patient asked for second opinion, and this is also very interesting. This was a relatively old lady, so you also have to live with this diagnosis of having a high-grade dysplasia in your stomach with an invisible lesion. So this is also psychologically not so easy.
Which people view differently, but yes.
Yes, but for this patient it was okay, and the patient was more concerned about the fact that she should undergo gastrectomy than to observe and follow up the lesion. So finally we were all very happy.
But still very tough case, huh?
Yes.
And you need a lot of time and aids and
Yeah.
If you didn't have the previous biopsy and had to screen the entire stomach?
So you mean with a type A gastritis?
Do you think that you would have found it as well? It's a theoretical question, but
I think we have to discuss, but this is another issue, how we perform the regular upper GI endoscopy. And I think in Europe we have the problem that we don't assess the stomach properly. And I think there are papers that if you have a gastric cancer for surgery, I think 10% of these patients got a previous upper GI endoscopy in the period of 3 years. Exactly. And I think we are most focused on esophagus, on Barrett's, on squamous cell, but stomach is a new challenge for us European endoscopists.
It's also a challenge because these lesions are so rare. So if you do this in every patient above the age of X...
but I think also in countries with higher incidence of Helicobacter, you have higher incidence of gastric cancer. So, in Switzerland, in the south part of Switzerland, we have higher incidence of Helicobacter. So I think we have to agree to be more precise.
Okay.
Okay, now second situation or setting, no visible lesion, and again biopsy proven poorly differentiated cancer. So this was a 53 years old female. She got a routine upper GI endoscopy, and the biopsy were taken from the stomach without any visible abnormalities, and now signaling cell cancer was detected. And also the problem here, all biopsies were in one container, and now
which you should not do in general.
So I think this is also discussion how you prove Helicobacter. So biopsies should be taken for detection of Helicobacter according to the guidelines, but then to put all in one container, I think somehow we always do it, you know.
Yeah. Some histopathologists who say that they can differentiate antrum from body.
Maybe yes, but...
Maybe yes, yeah.
Yeah. Okay, so what to do in this case? So I'm showing you now here this stomach. We also use the XZ1200 zoom endoscope. And when you look at this mucosa, there's everything is looks okay. You can only notice the areas of the previous biopsies. So this is here the corpus. And yeah.
So could you stop for a second?
Yes.
That's the second time you were mentioning the area of the previous biopsies in that. I think that's very important. So the first thing is not to do the follow-up gastroscopy too late.
Exactly. The most important is to re-endoscopy the patient very quickly, because in such a situation only the areas of the biopsies can help you to detect the area of the lesion. And what we did now in this case, this is again here, we are using TXI to better enhance light structure, but also with TXI we could not see anything. So what we did is we traced the previous biopsies, and then under video control we re-biopsied the areas of the previous biopsies. So this is biopsy 1.
Okay.
Yeah, I have to show you this because I think the approach is really important. Biopsy 2.
Absolutely.
Biopsy 3. So now we skip a little bit and we are coming now to the important area, biopsy number 8. It's in the corpus. And I'm showing you this area. So
the previous biopsy, there were 8 biopsies?
8 areas of biopsies, yes.
Oh,
yes.
That's unusual.
Yes. So the previous doctor was very precise. So in this area, we have to admit that there are also no mucosal changes, and this is now the undergrad view. Maybe there is a little bit a small whitish area, but this can also be a scar from the previous biopsy. And interestingly now in biopsy number 8, we found signaling cells.
In none of the others?
In none of the others. So yes, and here our pathologist did different staining, so you can nicely appreciate here these signaling cells.
So this was, in conclusion, this was so discrete
Yes.
that even sophisticated imaging was not really able to unequivocally detect it, and you did this biopsy scar directed approach.
Exactly, because in poorly differentiated cancer, in the early stage of the cancer, you have no changes of the mucosa. I will demonstrate you this later. The cancer starts from the neck of the glands, and then it spreads out to the submucosa first, and the mucosa is not involved in the cancer at the beginning, and that's why we definitely have an invisible cancer. The question is now what to do. So we have detected the area of the invisible cancer. So should we perform total gastrectomy? Is ESD indicated? So what is your opinion?
And we had many other biopsies, and this was
all negative.
seemingly the only
Yes,
area.
the only area.
And the patient is 53.
Exactly.
And no genetic abnormality.
No, this is important to exclude CDH1
Yes.
mutation. Patient had no CDH1 mutation, so I think theoretically ESD is an option.
It is. I think it's
Yeah.
a typical case of shared decision making. You give the patient the options. It could be total gastrectomy because there is some chance of recurrence, of course, or metachronous, not recurrence, but metachronous cancer. But you could also say if we have an ESD specimen, we have a better basis for deciding further.
Yes. That's true, but in this case we decided differently. So we discussed with our surgeon, and he recommended a partial atypical resection with sentinel node method. I think we have to admit for sure, with regard to the extended guidelines of the gastric ESD, we have to admit that this case would be acceptable for an ESD. Also, if you have a mucosal cancer, even I think there's a higher rate of lymph node metastasis in polydifferentiated cancer, but until a certain margin, this is accepted. But I think
So a diagnostic ESD would have been possible.
Would be fully correct. But in this case, we use this sentinel node method. So in this situation, we injected patent blue. And sentinel node method means that we detect the first lymph node after the tumor.
Can I ask one question to ESD? How big would ESD be?
I think minimum you should resect 5 centimeters around this biopsy area.
Okay,
Yes.
so rather big.
Rather big.
Okay,
Yes.
but now it's surgery.
Yeah. So we decided for surgery, but now we had to inject this patent blue in the area of the biopsy, and I honestly have to say, even we have known where the lesion was in the biopsy number 8, it was very difficult to relocate this area.
And you rebiopsied heavily.
We rebiopsied, yes, but you will notice now, this is I think 8 weeks later because we needed to prepare everything. So this underlines again how important it is to early rescope the patient after the first diagnosis. So this is the area number 8, and to be honest, I was a little bit, I didn't feel so well when the surgery was performed because I was afraid that I marked the wrong area. But here's again, you may notice here the video. And what we did, we placed the clip, and then we injected this patent blue in 4 areas around this clip. And this has to be done 1 hour before surgery. So
Into the submucosa.
Into the submucosa, exactly. And this is the operative specimen. So this is here the area. It's a huge piece, but it's better than total gastrectomy. And our pathologist could detect, luckily, this signaling cell cancer. Here you may appreciate the signaling cell cancer. And what you will notice here, this is everywhere regular mucosa. So this is a non-exposed early polydifferentiated cancer. So definitely endoscopically invisible.
Yeah, whatever you fantasize looking at the images, it's definitely invisible. Yeah.
Yes. So coming back again to
But what was the extension?
the extension,
it was scattered throughout. Right?
it was 8 millimeters.
The whole area.
The whole area.
And you had enough safety margin
Yes.
without any cells, so
Yes.
there's some likelihood that this was it.
Yes. So coming back now to the growth characteristics, this is here a paper from '85 from Japanese pathologist who described the growth characteristics of polydifferentiated cancer. So as I mentioned before, the cancer starts in the neck of the glands, and then the cancer cell appear to be shed into the stroma passively, and you will notice that these cancer cells occupy the lamina propria mucosae, and here at this stage potential imaging starts, because I will show you very interesting data. In this stage you may detect expanded glandular surface pattern, and we also know from the literature there are pale areas you have to look for. These pale areas can be the area of this early cancer. So here again a picture how the cancer grows, and now I would like to show you some data from Professor Inoue. He presented this at a magnification meeting 2015 at the DDW. So this is what we can see first. This is a non-exposed, poorly differentiated cancer with no changes of the mucosa. Only what you can see is that the pits of the glands are a little bit enlarged, and they did something very interestingly. After the resection, they stained with crystal violet, and here you nicely appreciate that there are different areas. So here we have the normal pits, this is the normal mucosa, and here this is the area of the non-exposed cancer. And here you nicely appreciate that when the cancer is growing here, as a first sign of imaging, you get this enlarged mucosal glands. And here you can also nicely see a delineation line. So this is normal mucosa background, and this is the cancer area. And when we compare the histology, this is regular mucosa. You see this is much larger here, and this is finally the first what we can detect in such a early cancer. So as long as the cancer hasn't reached the mucosa, we call it non-exposed type, and then when the cancer has reached the surface, then for sure we have then the exposed type of cancer.
Okay, but that's all imaging ex post, you know that there is something. Can we go back to the endoscopic image? Because among the next one? Yeah, right. So among the thousands and thousands of normal gastroscopies, how would you find that? Or, I mean, sometimes you have these whitish areas, but you don't really look at them. But this is a singular one to start with. So should you biopsy when you have this, it looks like a scar from the distance?
Yes. I think what we should conclude somehow, the sickness cell cancer, the location of sickness cell cancer is mostly the corpus. And this is the first signs of imaging what we could detect. So in any case, if you have such a finding that you have a small scar in regular gastric mucosa, you should definitely biopsy, because it's the only way to early detect this cancer.
And separately?
And separately, definitely.
If you have everything in one vial, then you at least know where this may come from, but it should be separate. But that's an important message, I think. So we have to direct our attention. So it's whitish.
Whitish.
You wonder, is it a scar that the patient has an ulcer? What's happening there? And it's in the body.
Exactly, in the body.
Okay, good.
So in this case, we performed surgery, partial gastrectomy. I would like to show you another case now, same situation, an 87-year-old female, and
which is also important, huh?
It's also important to note, yes. So biopsy were taken from the stomach, again without any visible abnormalities, and Signet ring cell cancer was also detected. Everything was in one container. And to show you also another case where it's not that easy, we referred the patient also 1 week after the biopsies, but here the whole stomach looks a little bit irregular. I think there are intestinal metaplasia.
So first thing is not clean enough, Japanese would say, right?
Exactly. So we detected, so we also traced the biopsy areas. So this is here one area in the corpus, And for us, this was the most suspicious area. Looked a little bit reddish, but yes. And then when you introduce the scope more into the distal part of the corpus, there's another area here with 2 areas of biopsies. And yes, what would you resect now when I ask you?
Well, would you go straight to resection now, or would you rebiopsy it?
In this case, the patient was 87 and somehow we had to make a decision. So,
but why not rebiopsying? It could have been 2 lesions.
It's one option to rebiopsy, but in this case we decided for resection, and we decided to resect this area because it looked for us somehow most suspicious.
The uglier one.
Yes.
And keep the other one in mind and biopsy them.
Exactly.
Okay, compromise.
So we did it, but no cancer in the yeasty specimen. So I only want to show this case that this may happen.
That's reality.
That's reality, exactly. So,
so what was histology? Inflammation, blah, blah, blah. Was there anything specific?
Inflammation, nothing, was type A gastritis. Nothing more, and some intestinal metaplasia.
So the pathologists leave us alone what that is. Okay.
This case happened some years ago. So in the report I wrote, I think we resected the suspicious area and we think that the cancer was removed by biopsy. That was my conclusion in the report, but the situation was in the follow-up different. I honestly tell this. So what did we do? We reanalyzed retrospectively the first endoscopy before ESD. And then, as I mentioned before, we had these other 2 areas, and especially in the follow-up, we specifically observed these 2 areas. And
you mean which 2 areas?
I think these are 2 biopsies here and here. They are very close together.
So one big area
Yes,
with
yes.
where 2 biopsies.
Yes, and this area is 49 centimeters, 6 o'clock, and this is a little bit more, 50 centimeter or 51. So yes, we scope patient every 6 months or every 8 months, and 14 months later, you notice that this area here is a little bit more white. So
you have your whitish sign. Huh?
Yes, we can call it whitish sign. It may be also related to the previous biopsies, but it looks a little bit more whitish. So we biopsied here, and there we found signaling cancer cells. So clear conclusion, the first ESD we resected the area with no cancer, and in this time, luckily, we could detect the correct area. I think this is scar biopsy, but here you see this slightly whitish, scary area. And this was an 8 by 4 millimeter
centimeter.
Millimeter.
The cancer.
The cancer only. The cancer is only 8 by 4 millimeter, non-exposed type, and it was exactly there in the area of the biopsy.
Well, if you look at the residual stomach, there are also some whitish areas here and there. So the patient, depending on the age, if she was much younger, would still undergo regular surveillance.
Exactly.
What kind of metachronous lesion rate do we have to reckon with if it's not a genetic abnormality?
I think 15% I would.
Over the years?
Yes, over the years, yes. So, these were 2 examples. I think in this context, we also have to discuss a little bit patients with CDH1 mutation, because there we also have the possibility of no visible lesion, but cancer may have developed already. And I would like to show you also 2 examples. This is one patient, she is 50 years old, she had ovarian cancer, and the CDH1 gene mutation was detected. And because there is the known association with hereditary diffuse gastric cancer syndrome, there's a clear indication for endoscopy, and we performed endoscopy in this case. And again, what I mentioned before, the predictive location for these early signaling cell cancer is the corpus. And here we could detect in this patient this whitish area in the area of the corpus. We biopsied this area, and exactly this was already early signaling cell cancer. And again, now back to the images. So this is white light. It is a little bit whitish. Here we can appreciate the advantage of TXI.
Is it larger here? Longitudinal or
no,
still the same?
It's still the same area, but this patient, we didn't perform surgery because she had metastasis of the ovarian cancer.
Okay.
So this question I cannot answer. But this is definitely the area of the biopsy with the cancer cells. And now again back to the imaging. It seems to be also already a non-exposed type, and here, if you look very accurate, you may notice that the glands are a little bit enlarged here in this whitish area. This
but
you
it's
can
more
also
impressive from some distance.
Exactly.
Yeah.
Here with NBI you can nicely appreciate this. And yes, our pathologist found here these cancers, and he also compared again the fact of non-exposed type, so there's no infiltration of the mucosa, and we also appreciate here these enlarged gastric foveolae in the biopsies. So I think this really shows that this is the first sign of imaging that we have enlarged gastric foveolae in such a patient. Again, here the signal ring cells, different stainings. Yes, and here again a comparison: normal mucosa and non-exposed cancer mucosa. So we have these enlarged foveolae. This is the situation of the non-exposed type, and here's our imaging. Yes.
Yeah, thank you, Stefan. That was a tough one. Can you show an even tougher one?
Yes, we have an even tougher one. We have a patient with a CDH1 gene mutation, 20-year-old female, and I think we cannot discuss all the facts of how to proceed and when to perform a gastrectomy, etc. But in this case, the familial history was that patient had 4 relatives with breast cancer and 2 relatives with stomach cancer, and that's why somehow patient was sent to our center for the decision making if gastrectomy should be performed. So what we did for sure, we did first endoscopy, and I'm showing you now here this
nice
cancer.
Picture of atrophic stomach, huh?
Yes, nice picture also, and we are using TXI, so you can nicely appreciate the superficial structures. But yes, there is absolutely no lesion. We only can see some areas of previous biopsies, like here. And I think for the follow-up of these patients, this is also a problem with these biopsy scars. And what I can tell you already, the cancer, which was finally then detected after gastrectomy, is located here in the corpus, proximal corpus. But there's really nothing, absolutely nothing visible in this upper GI endoscopy with a magnification endoscope. So we performed gastrectomy.
How long does this gastroscopy take? 15 minutes?
No, 30 minutes.
30 minutes.
Yes, 30 minutes. So and here in this case, the pathologist found signaling cell cancer, location proximal corpus, anterior wall, 3.5 centimeters distal of the Z-line after formalin fixation. Again, here the picture of the retrospective reassessment of this gastroscopy, so there's definitely no visible lesion in the proximal corpus anterior wall. Here again the histology, non-exposed type, and here are the signal ring cells, and watch the cancer size is 0.2 by 0.1
Three cancer cells.
millimeter, yes. So congratulations to the pathologist that he really has found this lesion. So what I want to say, we need a team for these patients. We need a good pathologist, and we also need a surgeon. And together with the endoscopist, we have to discuss.
But this was a gastrectomy on the basis of history.
Of history,
not of
exactly.
biopsies.
Not of biopsy. This was
okay.
the indication because patient had these specific circumstances of the mutation and also of the familial history of stomach cancer.
It's also quite some work for the histopathologist.
Exactly.
More than 30 minutes,
Yes.
maybe. Okay.
Yes. Okay, so I think it shows that
things can be difficult.
Things can be difficult, and invisible cancer proven by biopsy is still a big challenge for us.
No, absolutely. So thank you very much, Stefan. I'm afraid to the list of things for our nightmares, we now add the whitish spots in the stomach and think, wow, oh my God, what have we missed? But maybe you look out for those and make your own experience. And it's rare. So
it's
maybe
rare.
you have to biopsy 1,000 whitish spots or what you think are whitish spots to find one cancer.
Exactly.
Yeah. But thank you very much for showing us these limits or working at the limits of endoscopy.
Thank you.